Okay, and our final presentation today is from Charles Kocher, and he's going to enumerate optimal cancer treatment schedules.
Thanks. Yeah, so I'm Charles Kocher. I'm a postdoc at MSK. And so I have to admit, when I saw the schedule for the talks, I thought, oh no, I'm cursed with the last one before dinner. And then I showed up and I realized it's worse. I'm cursed with the last one before you get to go watch a beautiful sunset on the beach in paradise. But after listening to all the talks today, I'm actually happy that I'm last because I'm going to talk about a lot of the themes that everybody else had throughout their talks, and hopefully I'm going to cap everything kind of off here. With that, I just want to thank my co-authors, Joe Deasy, Damon Reed, Larry Norton, and my PI, Corey Weistuck. All the people I discussed this with, the Memorial Sloan Kettering Mathematical Oncology Initiative members, and funders. Okay. Good thing is I get to skip a lot of my intro because everybody already talked about it. But we all know that treatment failure follows a U-shaped curve. It's an example of evolutionary rescue that people have talked about. The one thing I want to add to what everybody said is there's an open data set called MSK Cord with this Nature 2024 paper. And so this is a real patient, breast cancer patient's data, a carcinoembryonic antigen over time during treatment. And you can clearly see these used, right? So this is a real thing. It's good to see the data every once in a while and say, yes, this is really something that happens in the clinic. We see the patient's CEA level go down, it reaches a minimum, and then it goes back up. And you can't see it on this plot because it's very small, but the treatment doesn't switch until imaging confirmed progression, which comes much later than the nadir of the U. So the question that we have is, after the minimum, continuing drug here doesn't actually decrease the population. Is this somehow, the best schedule? Can we do better? How can we change this situation? So um, again, something that a lot of people have touched on, standard of care is often maximum tolerated dose to progression. But what I want to add to that is that actually that's not always the case, right? So that's for most cancer types and most drugs, and especially in second line treatment. But there are cases where the clinical schedule is not just use one drug, use it till you progress off, and then you keep going. In particular, these alternating schedules. So for Ewing sarcoma, the standard of care treatment is you get surgery and you have VDC-IE alternating. So you take VDC and then 2 weeks later you get IE, and then 2 weeks later you get VDC again, and you keep going back and forth. So alternating drugs, this was an idea proposed in the 80s and even earlier by Goldie and Coldman, and it was popular to look at in the 90s, and it kind of faded. But then there are, these other alternate schedules that everybody's already talked about today, adaptive therapy, where you have treatment holidays depending on how your response does, and second or multiple strike therapies where you strike at the nadir. So my main question for this talk, and what I want to answer is if you give me everything there is to know about a patient's response to treatment, so you tell me exactly how that patient's going to do on all the given treatments that that patient can have, what's the best way to schedule those treatments to get some kind of optimal response? Okay. So to do this optimization, we need a model. For this work, I chose to use the GDRS model. So this comes from, Mark talked about this ETB work. It came out of the ETB study. It's in this 2023 preprint. It's a model that just has, tumor growth, the gamma term, death due to drug, a delta term. So the tumor volume or tumor population is the T equation. And then it has resistance and resensitization through this phenomenological drug efficacy E term. And so this is a model that's kind of like a very simple base model that can be easily extended to things like Gompertz growth or collateral sensitivities. You can include pharmacokinetics. Or if you have, everybody in this room has their favorite model that they've worked on, you can easily replace it in the optimization algorithm that I'm going to talk about. So anybody who wants to, say, oh, well, what is my, like when you try to optimize schedules, talk to me. We can do that. And then so I just want to talk about the resistance and resensitization parameters a little bit. Various mechanisms can contribute to these. So these are kind of phenomenological, kind of just descriptive parameters. They don't necessarily say, oh yeah, resensitization comes because the sensitive population is outcompeting the resistant one when the drug is off. It doesn't really say what the mechanism is. It just says that it happens, right? So this is a very kind of general model. And it's pretty light on parameters. And the point that I want to stress is that, it's pretty good at describing data. So if I looked at that patient from MSK Cord that I showed on a couple slides ago, and I just looked at all the U's in their trajectory, and I was like, okay, is this a model that, if you give me this data, can I go back and can I fit the parameters from it? The answer is yes. And it basically captures, how much does that CEA decrease, and what is the timing, right? So as far as the model goes, if you knew those parameters ahead of time, you would get a trajectory that kind of looks like the data. Okay, so now I want to talk about the optimization. And so I'm a physicist in training, so my background is physics. And so when I think about this drug optimization problem, a drug schedule kind of looks like a spin chain. So if there are other physicists in the room, you'll appreciate this. But what a spin chain is you just have a bunch of, say, atoms on a line, and then they have different spins of their, electrons are in different spin states, something like that. And you can map this problem kind of directly onto the drug scheduling problem. A drug schedule is nothing more than a list of things that you're doing in an order, right? So the idea that I had was, if you give me the GDRS parameters of a patient, I'm going to use a simulated annealing algorithm, something that you can do in mechanics or to deal with spin chains, to minimize the energy of that schedule. And I'm going to define the energy in a couple of slides to be clinically relevant things like minimizing the PFS or sorry, maximizing the PFS or minimizing the tumor burden. Just on what simulated annealing is for people who aren't familiar with it, it's an algorithm inspired by statistical mechanics. And what you do is, say you have a treatment schedule, and then at each time step, you make a change to it. So you add a drug, you change one of the drugs you're using, you take a drug out, something like that. And then you recompute your energy, your objective function. And you say, okay, does the new schedule do better than the old one? If it does, you accept the change. And if it doesn't, then you probabilistically accept the change. So you probabilistically accept it to stay out of like local minima, or to shape them so you can find the global minimum of your kind of energy landscape. And the way that this works is you can have a cooling schedule. So that's this red curve here. So for this beta parameter, so this is a Boltzmann form for accepting. It depends on the temperature. The temperature is the red curve, and then you can see the energy, which is the black curve, reaches some kind of minimum as you cool down, right? So that's how the algorithm sort of works. And so here are the energy functions that I use. So again, I had two objectives that were talked about kind of in Bob's talk: minimizing the tumor burden or maximizing progression, so cure or containment. And for minimizing the tumor burden, basically what the energy is, it's something like a log of the minimum tumor population that you reach on your trajectory. And for maximizing PFS, it goes as like 1 over a log of the PFS time. Okay, so now I want to talk about results. So I'm going to have some results for one drug, and then some preliminary results for 2 drugs, and then I'm going to talk about where we're going with this. So for one drug, if you run this and you try to optimize over various different parameters, various different ways to do this, you basically find that there are only 3 types of optimal schedules. 2 of them are adaptive therapies, and 1 is just continuous therapy. So for these results, I enforced a rest week in between treatments. So that's why you have these striped patterns. But continuous therapy is you just hit with drug every time you're able to. The first type of adaptive therapy is one that makes decisions based on the tumor burden. I'm calling it T-type. So you only hit with drug again when you're approaching that progression threshold. The other type of adaptive therapy, which is in the math but not necessarily a real solution, is what I'm calling E-type, which is where you hit with drug again once you've got your efficacy, which is the bottom plot, up to a certain level. So T-type, you make decisions based on tumor volume, parameter T in the model. E-type, you make decisions based on efficacy, E in the model. And so what we can do is we can plot out kind of like a phase space of the optimal strategies over different types of different parameter values. So each kind of dot in this plot would represent a patient. A patient has a certain resistance value, a certain resensitization value. So resistance is on the x-axis, Resensitization is on the y-axis. And you can see if you want to do like a curative therapy and minimize the tumor burden, there are basically only two types of optimal strategies. You can do the continuous strategy, which works for certain values, and you can do the E-type adaptive therapy, which works for other values. And if you want to maximize PFS, this T-type adaptive therapy comes in. It starts taking over for the continuous therapy because you can almost always, elongate your PFS time by having more doses in at the end, and instead of just continuously doing them. So for multiple drugs, so here are some preliminary results. Basically, the answer is that your favorite schedule is optimal somewhere, right? So some people will like second strikes, and I found that that's optimal when you want to minimize the tumor burden, but you have no resensitization. But if you turn resensitization on, then what you can find is that an alternating schedule actually reaches a lower minimum than a second strike. If you want to do PFS, if you have no resensitization, actually sequential maximum tolerated dose is the optimal schedule. It also ties with an alternating schedule. But if you turn resensitization on, you can get complex adaptive-like therapies. So, you couldn't have predicted this adaptive therapy schedule when to turn the drug on and off, beforehand. It's just something that pops out of the model. And if you run the simulated annealing algorithm multiple times, you just get back this exact kind of funny schedule with all of its peculiarities. So I just want to summarize. I used a simulated annealing algorithm to find the optimal treatment schedule for a patient given their GDS model parameters. For one drug, there was only 3 types of optimal schedules, 2 adaptive and 1 continuous therapy. For 2 drugs, basically all the schedules that are used in the clinic are optimal somewhere. So we have to explore this more, but up front that suggests that you need to do personalization very early, right? Because if you have different patients with different parameter values, they're going to lie in different spots on this parameter space, and so you could be on different sides of these phase kind of boundaries in your phase diagram. And so we can extend this work, with all the fun models that everybody kind of had today to capture more complicated kind of drug response parameters. And so I just want to close by putting this kind of into perspective. So I've been at MSK for, I think it's 6 or 7 months now. And so this is kind of where we're going. What we want to do is if we get a new patient, we want to take, baseline data on that patient, classify them, say predict their model parameters, and then use this kind of digital twin simulated annealing algorithm framework to predict the best treatment. Then we want to see what happens with that treatment and make real-time, treatment decisions based on what's going on, updating our model parameters, and things like that. But then we also want to do this after action report that Bob was talking about in his talk, where we go back and we say, okay, how can we fix the model based on what we observed? And how can we, calibrate the model with, say, KM curves from clinical trials that have already been done, in vitro experiments and cell lines. And so, towards this direction, what I want to point out is from this MSK core cohort, this MSK core data set, I've taken out, all the breast cancer patients. I've taken out their CEA responses, in particular to the drug paclitaxel, and I've just fit the GDR parameters, right? And so you can get a cohort. So I think that data sets like that are going to be a big help in sort of calibrating models. Just, you can get clouds of patients and say, look, who am I most like? So yeah, with that, thanks for listening, and I'll be happy to take questions. Ready?
Charles, that was fantastic. Good to see you.
Yeah, see you.
Boy, and congratulations on what you've achieved over a really short amount of time. So in your E strategy, which I love, because that's where sitting here with Dawn, who's looking for ways to treat patients, if you could run the disease into the ground. And I think, questions have been coming up as to whether one can use kind of an evolutionary therapy approach and run it into the ground. Whereas if you go the T approach, you essentially are accepting the fact that you're going to be maintaining a high tumor burden. Do you think if you didn't know, so let's say you didn't know the actual underlying parameters, can you come up with a strategy that would let you know whether you could use an E approach or you should just fall back on the T approach?
Yeah, that's a good question. Probably you would have to defer to kind of like previous experience. You'd have to say, okay, has this disease been cured ever before? Sometimes the answer is no. Sometimes the answer is yes. If it has, then maybe you could try to do the E approach. But really, I think the way to do it is, maybe we don't know patient specific parameters, but we can make, cohorts of just, we've had people with this disease before. We can say, okay, what are the range of parameter values and where does that fall? And maybe some of those patients, you can do one strategy or another, but maybe sometimes that'll just always fall in one area. So that's one of the things I want to explore is, okay, what are the actual parameter values for, different patients? What are the distributions that you get when you take cohorts of patients? And that's sort of, what I'm trying to do down here with these responses to paclitaxel is just say, what are the actual values of these patients? What's the spread look like? Yeah.
Let's thank the speaker.